this video, we will be focused on Parkinson's disease and the various treatment options available, all of which will be symptomatic treatments, because none of these will actually treat the cause or restore the function that has been lost in Parkinson's. So the function in question is of the dopaminergic neurons found in the substantia nigra that are incredibly important for regulating motor function. And motor function is going to be the primary focus of this particular video, but know that this loss of dopaminergic neurons leads to a slew of other effects that explains the other signs and symptoms of Parkinson's disease that are not motor related. So we will start off like we normally do with normal dopamine metabolism, transport, and signaling pathways that are again going to be crucial for promoting that normal motor function that can become imbalanced in Parkinson's disease. And we will start with the amino acids like tyrosine, which are transported from the systemic circulation across the blood-brain barrier and into those dopaminergic neurons, using the amino acid transporters that are already present on these membranes. So once inside, tyrosine hydroxylase will then convert that tyrosine to L-dopa, which is then converted to dopamine by dopa decarboxylase. The newly generated dopamine is then packaged into vesicles to await that action potential and that influx of calcium ions that we've talked about in other videos that will trigger the mobilization of those vesicles to eventually fuse with the presynaptic neuronal membrane and release that dopamine into the synaptic cleft. That dopamine release can then either bind the D1-like dopamine receptors, which include D1 and D5 receptors, and these are going to be coupled to GS and lead to downstream stimulatory effects in the direct pathway. So on the other hand, when dopamine binds the D2-like receptors, which are D2, D3, and D4, these are coupled to GI and will lead to inhibitory signals, but in the indirect pathway. So in this video, I won't get into the direct versus the indirect pathways, but just know that together the inputs from both of these triggered by dopamine promotes intended movements and prevent unintended movements. So when dopamine in the synaptic cleft is no longer needed, the presynaptic dopamine transporter moves dopamine back into the nerve terminal to be recycled into vesicles to be released again with that next signal propagation. In addition to signals from these two groups of dopamine receptors, there are also nearby neurons capable of releasing other neurotransmitters to act upon different receptors on that postsynaptic membrane to modulate this dopaminergic signaling to alter motor function downstream. So the first neurotransmitter that we're going to discuss, and we will come back to several times in this video, will be acetylcholine. So acetylcholine and dopamine essentially counteract each other in the indirect and direct pathways and are thought to be in a state of balance. So when acetylcholine is released from these nearby neurons, then the acetylcholine will bind the muscarinic receptors and further modulate and balance those dopaminergic signals. Glutamate can also be released from nearby neurons to act upon the NMDA receptors, which, remember, are those ionotropic receptors to allow for the influx of ions to further modulate these signals. So keep these modulatory options in mind, in addition to our more direct dopamine signaling cascade. Well, we've discussed dopamine synthesis, release, and signaling. Now let's discuss dopamine metabolism. Because in addition to our dopamine transporters, to turn off dopamine signals, we also have enzymes that can break down dopamine. So we'll start off in our dopaminergic neurons themselves with our monoamine oxidase enzymes, which are responsible for inactivating an assortment of monoamine neurotransmitters like dopamine. And there are two flavors, being our monoamine oxidase A and monoamine oxidase B, which decorate the outer membrane of our mitochondria. So both can be found throughout the body and in neurons, and these enzymes will act upon dopamine, oxidizing it to inactive metabolites and hydrogen peroxide. So this hydrogen peroxide can form free radicals, but ideally scavengers are present to accommodate this oxidative stress. So this is in the neurons. What about metabolic enzymes in the circulation? Because as you can imagine, inappropriate circulating dopamine levels can lead to a lot of systemic side effects. So outside the blood-brain barrier, tyrosine can similarly become L-dopa and then dopamine, which can then be acted upon by catechol-O-methyltransferase or COMT enzymes, which methylates and inactivates catecholamines like dopamine. So these COMT enzymes can be found centrally and peripherally, but for today, we're really just going to focus on the peripheral population today. So now we've covered our simplified overview of dopamine synthesis, transport, signaling, and metabolism. That is all key for promoting intended movements and preventing unintended movements and achieving that motor balance. But what happens that leads to the imbalance that defines Parkinson's disease? So moving to our next slide. So Parkinson's disease is defined by an assortment of motor and non-motor symptoms, which have a few handy mnemonics. The imbalance that defines intended movements and preventing unintended movements and achieving that motor balance. But what happens that leads to the imbalance that defines Parkinson's disease? So moving to our next slide. So Parkinson's disease is defined by an assortment of motor and non-motor symptoms, which have a few handy mnemonics. So for our motor symptoms, we have TRAP, which stands for tremor at rest. We have rigidity, akinesia or bradykinesia, and postural or gait instability. The non-motor mnemonic is SOAP, which isn't the most helpful mnemonic, but it's better than nothing, and it stands for sleep disturbances, other miscellaneous symptoms, autonomic symptoms, and psychological symptoms. But today we are again going to focus mostly on our motor symptoms, and the reason for these is Parkinson's disease is caused by a lack of dopamine. And this is a progressive neurodegenerative disease that leads to the gradual loss of our dopaminergic neurons in the substantia nigra. Once a patient has lost a substantial proportion of these neurons, like somewhere over 50%, these motor symptoms become much more apparent. So the cause of this degeneration is not entirely clear, but there may be many processes that are involved playing a role in this neuronal apoptosis that leads to the dopamine deficiency. So without sufficient dopamine, we no longer have that appropriate balance between dopamine and acetylcholine. So we lose this balance that's necessary for promoting those intended and preventing those unintended movements. And we end up with this slew of symptoms. So to correct this, we have no agents that are available that can restore those lost dopaminergic neurons. But we can either increase dopamine signaling, which is the primary strategy usually used, or we can reduce the acetylcholine signaling, which is uninhibited in Parkinson's disease. So moving to our next slide. So we will start off our discussion with the agents that increase dopamine signaling, and this group is going to include supplementing with dopamine precursors, metabolic enzyme inhibitors to boost dopamine levels and prolong its half-life, as well as dopamine receptor agonists. And we will start off with dopamine supplementation on this slide with levodopa. And this is the metabolic precursor for dopamine. So once the levodopa is able to reach those presynaptic terminals, it is converted, just like before, by dopa decarboxylase to dopamine, and then can proceed through its normal packaging, transport, signaling, and metabolic pathways, just like endogenous molecules, which is a bonus because precursor supplementation allows the body's normal regulatory mechanisms to dictate when this has its effect and when it doesn't. Now let's take a second and talk about levodopa's path after oral administration. So when taken orally, it is rapidly absorbed by amino acid transport systems in the small intestines. So you don't want to take this with a high protein meal because the amino acids from that meal may compete with the transport for levodopa. So this would affect its bioavailability. So now levodopa has been absorbed into the systemic circulation. But as you can imagine that dopamine is needed both inside and outside that blood-brain barrier. And in the periphery, we also have those dopa decarboxylase enzymes that can convert levodopa to dopamine, which is bad for several reasons. First, that dopamine is not going to be able to cross the blood-brain barrier. But levodopa is hijacking those amino acid transporters to gain access. But if this conversion happens before levodopa can get into the blood-brain barrier, then none of that dopamine can be supplemented in the CNS. So no intended effects. Reason number two, now we have a lot of dopamine that's being generated from levodopa. So there will be now a high risk of dopaminergic side effects like severe nausea, drowsiness, and orthostatic hypotension. So no efficacy and lots of toxicity. But what we can do is we can inhibit peripheral dopa decarboxylase by administering an inhibitor that cannot cross the blood-brain barrier. So levodopa stays levodopa, and this inhibitor is called carbidopa. And the addition of carbidopa is a key component in levodopa therapy and significantly increases the blood-brain barrier bioavailability of levodopa so that it can actually reach its target and do its thing. So not only do we need to worry about dopa decarboxylase in the periphery, we also need to worry about those COMT enzymes that can not only methylate and inactivate dopamine, but also levodopa or L-dopa, which would lead to inactive metabolites and now of no use. So to combat these COMT enzymes, we have peripheral COMT enzyme inhibitors like entacapone, which is the most commonly used agent of this class. But there is another agent I just want to mention that's called tolcapone, and this is actually a peripheral and centrally acting COMT inhibitor, but its clinical utility is pretty limited because it comes with a risk of fatal hepatotoxicity. So the combination of levodopa, carbidopa, and plus or minus a COMT inhibitor are very commonly used combinations for the treatment of Parkinson's disease. And once started, these levodopa combo meds are titrated up to effect and is generally considered the most effective option. However, we already discussed that it does come with those dopaminergic side effects, but there are also other effects patients may experience. So sort of like insulin, we can give both immediate release and controlled release levodopa combinations to say help get the patient moving initially in the morning and maintain them over the day, for instance, which works for a while. However, with chronic therapy, this can lead to motor response fluctuations, as well as dyskinesia. So we will first start off by discussing dyskinesia, which is an uncontrolled involuntary movement, and this happens with chronic levodopa therapy because though we try, we cannot fully recapitulate dopamine levels over the day, which the body responds to with a hypersensitive response when dopamine is actually present, which is why at high doses or peak onset is when these dyskinetic movements occur most or when they are worst. So keep this in mind while we discuss our motor fluctuations, which can be either wearing off phenomenon or in more extreme cases on-off phenomenons. Where wearing off is just as it sounds, where it's a more gradual loss of levodopa rescue, or it can be on-off phenomenon, which is a much more rapid transition from dyskinesia to brady or akinesia. And this reflects the therapeutic window changing over time with therapy. So let's take a minute to just visualize what this changing therapeutic window looks like over time. So on our x-axis, we have time on chronic levodopa therapy. And then on our y-axis, we have drug concentration, so our levodopa. And generally, our fluctuations throughout the day are going to look like this with administration. Where initially, when we start off on levodopa therapy, we have those beneficial effects to where we can minimize that off time, which would be that time below that minimum effective concentration, maximize our on time, and avoid any time in this region that would be beyond that minimum toxic concentration where those dyskinesias would start. However, over time, because we have this progressive loss of dopamine and more dopaminergic neurons, we lose that dopamine that's supplementing our levodopa. We also start getting those hypersensitive response to our levodopa chronic therapy that we talked about. So the therapeutic window essentially narrows on us, where we're spending more time in dyskinesia because of that hyper responsiveness, and we're spending more time in bradykinesia phases, or when we have that off time, where we see that wearing off effect. And over time, this further narrows and progresses to where we might have those rapid on-off transitions from dyskinesia to bradykinesia with levodopa administration. So the main takeaways from these agents we discussed on the slide is that levodopa monotherapy is ineffective, but combinations with carbidopa is a common first-line option. But over time, there can be fluctuations in efficacy and toxicity, which may warrant the addition of a COMT inhibitor or other agents, which brings me to our dopamine receptor agonists on our next slide. Now, the dopamine receptor agonists include agents like pramipexole and ropinirole, and do just what their class name implies as dopamine receptor agonists, where they will bind and activate either dopamine 1-like receptors or dopamine 2-like receptors, just like dopamine, but with different affinities, to promote those intended movements and prevent those unintended movements. However, in contrast to levodopa, we lose that ability for the body to use its own dopamine regulatory mechanisms. So these agents can be used first before levodopa and may help delay the need for starting levodopa and those chronic motor concerns that come with therapy, or they can be added to levodopa to help with that wearing off phenomenon that occurs with chronic therapy that we just discussed. And as you would expect, there are going to be similar side effects as levodopa that are dopamine related, but these agents come with a higher risk of hallucinations, sleep attacks, and impulsive behaviors. Because of this, these agents should be started low and titrated slowly over time, and if intolerable or some of these more impulsive behaviors appear, discontinuation is going to be necessary. So one agent I specifically want to highlight is apomorphine, which is reserved for rescue therapy for severe off episodes, and this is because of the risks associated with this agent. So apomorphine is given sub-Q under medical supervision because of the need for pre-medication, because it is incredibly emetogenic, leads to significant drowsiness, QT prolongation, and there is abuse potential. So beyond these trends, there is a lot of variability within this class of dopamine receptor agonists, but these are really the main take-home points for this class. So moving to our next slide. Our next group of agents are going to require us to return to a class of metabolic enzyme inhibitors, being the monoamine oxidase inhibitors, or the MAOIs, which we are specifically going to be discussing MAOB inhibitors, like rosegeline and selegiline. And these are irreversible inhibitors of MAOB, which means to restore MAOB function, transcription and translation are needed. So we're going to have a more dramatic effect with these inhibitors. But these agents will prevent that inactivation of dopamine so that this can be recycled back into the vesicles and further participate in signaling. So we're boosting the level of dopamine as well as its half-life. So these agents will come with many of the same dopaminergic related side effects, and their place in therapy is really going to depend upon the specific agent in question. Now, there are two common concerns with these agents that we're going to go through now to save us a little bit more time later on in the block, and that is going to be tyramine reaction and serotonin syndrome. Starting with our tyramine reaction. So tyramine is found in a number of foods like wine, cheese, chocolate, meats, etc. And increased tyramine in the diet downstream is converted into norepinephrine and epinephrine, which are normally metabolized by monoamine oxidase enzymes, but usually monoamine oxidase A. But at high doses, our monoamine oxidase B inhibitors lose selectivity and can inhibit those A enzymes, which means with a tyramine-rich diet, you have high levels of adrenergic neurotransmitters, leading potentially to elevated blood pressure and heart rate, all the way potentially leading to a hypertensive crisis. So this is why with these agents, a tyramine-restricted diet is recommended. Now, serotonin syndrome is similar, but more of a drug-drug interaction instead of a drug-food interaction, like with MAOIs, like our MAO-B inhibitors, and other serotonergic medications. And this we will get later on in the block, but together these serotonergic medications with our MAOIs leads to increased serotonin levels. That can also lead to a hypertensive crisis as well as arrhythmia, fever, muscle rigidity, and seizures. And this reaction can be life-threatening and usually occurs pretty soon after combining the culprit drugs together. And this is why this particular class of agents is contraindicated with the use of other drugs with MAOI activity or other serotonergic agents. And if one of these agents needs to be started, you need at least a 14-day washout period between discontinuing and starting the new serotonergic or MAOI agent. So because of these risks, these agents are not as common for this indication. So moving to our next slide. So now we are going to transition to our agents that will help restore that balance between dopamine and acetylcholine by reducing that cholinergic signaling. And we will start off with our anticholinergics, like benztropine, for instance, which is going to bind to muscarinic receptors, whose effects would normally counteract that dopamine and restore balance. Now, I will not go over the anticholinergic toxidrome again, but revisit that for the symptoms patients will be at risk for. Also, these agents are on the Beers criteria list, so caution should be taken with geriatric patients, and these agents should not be used if avoidable. And because of the side effects of this class, it's not super commonly used anymore. Now, the last agent we're going to discuss in this video is amantadine, which has a few potential mechanisms of action and is technically an antiviral medication. So the first mechanism being anticholinergic effects, similar to benztropine. Also binding our NMDA receptors and acting as an antagonist and prevent that signal input. And this agent is also thought to promote that dopamine release as well as prevent its uptake by those transporters. So together, all of these mechanisms of action are thought to play a role in amantadine's efficacy. So the side effect profile for this agent is going to be really similar to what you would expect for an agent that has anticholinergic as well as dopaminergic effects. So both the anticholinergics and amantadine have some benefits, especially with tremor and excessive salivation, which is common in Parkinson's, but because of the anticholinergic risks in elderly patients, the use of these agents is not super common. So moving on to our summary slide. So in summary, the loss of dopaminergic neurons from the substantia nigra leads to an imbalance between dopamine and acetylcholine, which leads to a decreased ability to promote intended movements, resulting in bradykinesia and akinesia, and inhibit those unintended movements, leading to dyskinesias. So this imbalance is primarily corrected through the supplementation of dopamine precursors, and these are combined with dopamine metabolic enzyme inhibitors to ensure CNS distribution and increase precursor levels and half-life. So alternatively or supplementally, dopamine receptor agonists can be used, which come with a different set of risks and benefits. So another way in which balance can be promoted is with anticholinergic agents, which lower that acetylcholine signaling to match the dopamine loss, but the side effect profile usually limits their use. Now, it's important to note that these are all symptomatic treatments, since we cannot regenerate dopaminergic neurons that are lost, and setting appropriate expectations regarding long-term treatment with these agents and the potential consequences of treatment will be crucial.